Back in the spring of 2020, if you were listening to this podcast back then, we met a woman named Stephanie Dustin and her daughter, Charlotte.
Hey, sweetie. How are you doing? Good. How did you feel when you had coronavirus?
Bad.
Why?
I don't know.
What felt bad?
I don't know.
Charlotte was 3, and she was among the first wave of Americans to get infected with the novel coronavirus.
What felt bad?
My legs.
Your legs. How do you feel now?
Good.
You feel good? Why do you feel good?
Because I'm out of the hospital.
Because you're out of the hospital.
Okay, so Charlotte, she tested positive for coronavirus in February of 2020 on a regular PCR before they had the actual COVID-19 tests. She developed myositis and some really serious inflammation. And since then, she has been in and out of the hospital with really severe immune dysregulation. So has her sister.
Charlotte's sister, Elizabeth. She was 6 back then, so Stephanie had 2 young children sick with COVID back when it wasn't entirely clear how dangerous it might be to kids.
It was a lot happening at one time. So there was definitely respiratory stuff going on. So they both had a lot of stomach pain. They had a cough. They had congestion. It sounded like a bronchitis cough. Elizabeth had really high fevers. Charlotte ended up having significant weight loss just because I think she wasn't eating and there was fatigue. And then Charlotte was severe enough to where we were taking her to the hospital, quite a bit. And then Elizabeth was able to stay home, but things for Elizabeth just progressively got worse.
Both Charlotte and Elizabeth had symptoms of systemic inflammation. Now, at the time, Charlotte was diagnosed with Kawasaki disease, which is an illness that causes inflammation in blood vessels all throughout your body. Now, doctors recognize this as multi-system inflammatory syndrome in children, or MISC, now a well-known COVID complication in kids. In the year plus since, neither child's immune system has entirely settled down. Stephanie calls what they're experiencing immune dysregulation.
So immune dysregulation for her looks like really severe rashes, joint swelling, joint pain, difficulty walking, fatigue, difficulty breathing at times, episcleritis, where her eyes turn really red and they hurt, migraines, and medication to manage a lot of it.
Which sounds an awful lot like the symptoms of MISC, but their doctors don't really know what's going on exactly. They do know that since recovering from COVID, another disease has emerged for Elizabeth to fight. It's an autoimmune condition that causes muscle weakness and rapid fatigue in the arms and legs.
So every 28 days, she is admitted for something called IV immunoglobulins, which is IVIG, to treat her neuromuscular disease called myasthenia gravis. And treatment helps her be able to be a normal kid that can go to the park and play and do all of the normal things.
Doctors won't say COVID caused Elizabeth to develop myasthenia gravis. In fact, some say one thing has nothing to do with the other, while others are exploring possible links between the two diseases. It's more likely, though, that Elizabeth was already vulnerable to developing myasthenia gravis, or was perhaps even experiencing mild symptoms of the disease when COVID came along and made it much, much worse. Sort of like if myasthenia gravis was a puddle of gas, right? And COVID was a lit match. Keep the puddle of gas and the lit match separate, no problem. Toss the match into the puddle, though, and you have a fire. So I reached out to Stephanie to check on her and the girls, in part because I was curious about whether they would be getting the COVID vaccine. Charlotte will soon be 5. Elizabeth is 8. First, though, knowing everything COVID has put this family through, I wanted to know how Stephanie feels when she hears other parents minimize the risk posed by COVID to children, saying they can't get it or, that it's no worse than a cold or the flu.
My heart shatters. Sorry. Because so many of those parents, they don't know if they're going to end up having the child that ends up having COVID and then something catastrophic happens. And it's just hard. It's hard to hear.
Will Stephanie's children be vaccinated?
So Elizabeth got her first vaccination today when she was being discharged from the hospital. So that was an exciting day. And she will get her second dose during her next admission. She's admitted to the hospital every 28 days for her treatment. And Charlotte will be getting her first vaccine on December 7th.
But doesn't she worry about risk? I mean, she's been through so much. Does Stephanie have any vaccine hesitancy at all?
I don't, because when you weigh the risks and the benefits, it's not even a question. If my kids were to get COVID again, I don't know if they'd make it through it. And I think at some point, parents have to have trust in the FDA, have trust in the NIH, have trust in these scientists and doctors that are working day and night to try to help stop this pandemic and not have the severe side effects that people are having from COVID. It's just not even a question to me.
But for many parents, there are questions. They are vaccine hesitant, and I think understandably so. So let's dive in and get some answers for them, from risks versus benefits to whether you should give your children Tylenol before they get their shot. From Texas Public Radio and the Texas Newsroom, this is Petri Dish. I'm Bonnie Petrie. In this episode, we are talking about kids and the COVID vaccine. On November 3rd, 2021, the Food and Drug Administration announced that children between the ages of 5 and 11, elementary school-aged kids, would now be eligible for the Pfizer-BioNTech COVID vaccine, and within a week from that announcement, the White House says around 1 million children got their first shot. That's a big number, 1 million. And it's an exciting development to the fight to end the pandemic in the United States. But that leaves around 27 million kids who are now eligible to get the shot who have not yet gotten their first dose. Now, that's not really a surprise. It's taking a minute for doctors' offices and clinics and pharmacies to get stocked up on the smaller, differently packaged kid-sized vaccine doses. And initial demand has been really high, so it's going to take some time to get the vaccines into every waiting elementary school kid's arms. There is a line right now. But if the vaccine rollout in this age group follows the pattern set by other age groups, we can expect that early rush to vaccinate to slow down significantly as the weeks go by. In fact, there is a significant number of parents who say they will take a wait-and-see approach with their kids and this vaccine, letting the eager parents and their kids go first. Or they have questions about the vaccine and their kids, and they don't know who to ask. So they're waiting, and they're wondering, while their children remain vulnerable heading into another winter. So let's see if we can get those questions answered right now with epidemiologist Caitlin Jetelina, no doubt known to some of you on the internet as your local epidemiologist, and Dallas pediatrician Ellie Wolovitz. I talked to both of them right after the announcement that 5 to 11-year-olds were now eligible for the vaccine, and they were both thrilled.
So psyched. We've been waiting for this. It's awesome. I'm so excited.
Really big news, really welcome news, honestly. Any step forward to get us out of this pandemic is one to be celebrated, I think.
Let's start with Dr. Wulovitz, who sees elementary school kids every day. So why is this decision to let these kids get vaccinated such a big deal to you?
I mean, grandparents have gotten vaccines, parents have gotten vaccines, people are ready to, move on with their lives. And with children under 11, we've had to send them back to school unvaccinated and vulnerable. And I think with the Delta wave, we really saw that children are absolutely part of the cycle of spreading the virus and that they can get sick, they can spread the infection, and having them vaccinated is a crucial portion of, achieving some semblance of herd immunity.
There's this persistent myth that kids don't get infected with COVID, or if they do, they don't really get that sick. So the thinking goes that the vaccine may be more risky for kids than actually getting the virus and, letting their body fight it off. But as we heard from Stephanie at the beginning of the show, both of her young daughters got COVID, and it has been extremely difficult for them, and it hasn't stopped being difficult a year and a half later. So, Dr. Jetelina, you've been crunching the numbers since the beginning of the pandemic. What is the truth about kids and COVID?
So I think we've done ourselves a disservice for, always comparing kid outcomes to parent outcomes. But kids aren't spared from this pandemic. More than 1.9 million 5 to 11-year-olds have been infected by COVID-19. More than 8,300 hospitalizations among this age group. More recently, COVID-19 has jumped to the 6th leading cause of death in this age group. So, kids aren't supposed to die, but COVID is getting to a few select unlucky kids. And, this vaccine makes this a preventable disease. And so it is quite important, and it's very needed right now.
Dr. Wulovitz, what have you seen regarding COVID and kids in Dallas?
Well, at one point we had 17 children in the ICU at Children's with COVID-19. So we're absolutely seeing that children can get very sick. Now, the majority do fine, and that's wonderful, but it is the 6th leading cause of death. I think, one of the things that is so worrisome too is that during this Delta wave, where we were seeing an increase in pediatric hospitalizations like we hadn't seen prior in the pandemic, 32% of those kids were, previously healthy kids with no underlying conditions. So, yes, thankfully children haven't, died in the numbers that we've seen, older people and people at risk, but absolutely children can get it, can get very sick, can unfortunately die. So that might have previously been the thinking in the past year before Delta, right? But Delta changed everything. And so at this point, the benefits of the vaccine and how many hospitalizations that will prevent from COVID-19 outweighs the risks of hospitalizations associated with vaccine-induced myocarditis, which was, that is the thing we worry about. That is the safety signal. That's what kids have been hospitalized for. Now, I will say that the kids that have been hospitalized for vaccine-induced myocarditis have been, overall fine and have been admitted for observation, right? They have been admitted over an abundance of caution to watch them closely for 48 hours and follow their enzymes and make sure that their body's recovering. But for the most part, those children got ibuprofen and were discharged home the next day. So when you see hospitalizations from vaccine-induced myocarditis, you need to think these were children who came in with chest pain, had an elevated enzyme level, and were admitted to the hospital just to watch them. It's not like they were in the intensive care.
Myocarditis is a scary potential complication, though. I mean, inflammation around the heart that can lead to an abnormal heartbeat, heart failure, sudden death. That's a complication I'm going to pay attention to and worry about and make decisions around. So, Dr. Jetelina, talk to me more about myocarditis and vaccines.
So myocarditis is a concern, and that was a concern that we identified through our surveillance system about 1 month after the adolescent vaccine. It's a true safety signal, so it's been shown to be directly caused by the vaccine, but it's incredibly rare. So because it's incredibly rare, no cases of myocarditis popped up during this 5 to 11-year-old clinical trial. And this is great, but we really expected it. Because it's so rare, we need a really large proportion of people in a clinical trial. That's just not feasible time-wise or money-wise. And so what we have to do is outweigh the benefits with risks of myocarditis going forward. And the CDC and FDA ran a couple of really intensive models about what's the possible rate of myocarditis in 5 to 11-year-olds, and does the vaccine continue to outweigh the risks? And it does. For about every 1 million doses, about 60 young males may experience myocarditis. The other really important thing to recognize is that vaccine-induced myocarditis is very different than classically induced myocarditis. So, before pandemic times, kids got myocarditis all the time from bacteria and other viruses. That classic myocarditis is very severe. We're trained in epidemiology and medicine that with classic myocarditis, 1/3 of kids will die, 1/3 of kids will need a transplant, and 1/3 of kids will go home. So that's classic myocarditis. So at the beginning, we were starting to get very nervous seeing vaccine-induced myocarditis, but it's much more mild. Of all of the cases that we've tracked and we've identified in the United States, there have been no deaths linked to it, and all of the kids fully recover within an average of 34 days. And so that's very promising as well.
That's reassuring that vaccine-induced myocarditis has not been found to be anywhere near as serious as virus-induced myocarditis. Also, that no cases of myocarditis were found in the 5 to 11-year-olds who were in the Pfizer trial for the COVID vaccine. All good. But some parents still worry that the trial wasn't big enough or long enough to really tell us anything about the safety of the vaccine.
So the clinical trial was actually pretty big, and it's bigger than we've had in the past with vaccines. Interestingly, the clinical trial was organized into basically 2 cohorts. The first was the phase 3 cohort was about 2,300 kids aged 5 to 11 years old. And then the FDA asked Pfizer for a safety expansion group, which was basically the addition of about 2,400 more participants that were followed a couple weeks after that second dose too. And this really allowed for a more robust assessment of severe adverse events.
How well did it work in trials?
It looks like there's about a 91% efficacy rate for 5 to 11-year-olds, which if we remember before the pandemic, our goal was 50% efficacy. So 91% efficacy is just fantastic. The other thing we learned about the clinical trials was the vaccine works fantastically against Delta, which is the variant that's circulating in the United States right now, which is very promising news. So we know that the vaccine works really great. We also know the vaccine is safe as well. There are going to be side effects. 5 to 11-year-olds will probably experience maybe a fever, chills, joint pain, but this should go away in about 48 hours. And adults, we all kind of experience this too, at least us unlucky ones did. The other thing is that there were 2 adverse side effects that did pop up. One was swollen lymph nodes. So 13 people that got the vaccine in the clinical trial had swollen lymph nodes. This is very normal. We also saw this happen with adults. And this is basically a sign your immune system is working. It's engaged. That also is very temporary. The other thing we saw in the 5 to 11-year-old clinical trial was hypersensitivity. So the child may get a little rash around the injection site.
And I'm guessing that the research on this vaccine and kids is not over, right?
Yes. So the clinical trial is ongoing. So if we remember that this is actually an EUA. So for an EUA, we only need 2 months of follow-up data. For full licensure, which is expected of vaccine sponsors, if you get an EUA, they need 6 months of follow-up data. But even after they get full licensure in spring, they're going to be following these kids for 2 years. And honestly, they'll probably be followed for their lifetime, just because of how much these clinical trials are under the microscope right now.
Support for the Petri Dish podcast comes from Pay It Forward, providing sober living for newly recovering individuals with 92% success completion rate, allowing them to achieve self-sufficiency and long-term recovery. More at payitforwardsa.org.
So let's talk about dose size. Adults and adolescents have gotten larger doses of the Pfizer vaccine, and 11-year-olds are getting little tiny ones.
It is. It's actually a much smaller dose than the adult vaccine. It's about 1/3 the dose, so 10 micrograms. The adult the 12 plus dose was 30 micrograms. Because it's a smaller dose too, though, we're seeing less prevalence of side effects, which is also, I think, welcoming to a lot of parents. And we expect the risk of myocarditis will also decrease because of that as well.
Interestingly, if you have a larger 11-year-old and a smaller 12-year-old, the larger 11-year-old will still only get 10 micrograms of vaccine, while the small 12-year-old will still get 30. Now, that's because, unlike most medicines, vaccines aren't size or weight dependent. If you're bigger, you might need more of a certain type of medicine for it to work. But vaccines target your immune system. They are teaching your immune system how to fight something, right? And your immune system changes over time with physical development. So 5 to 11-year-olds have really robust immune systems, and this research has found that it doesn't take nearly as much of the COVID vaccine to get those young immune systems revved up and ready to learn. So they were looking for a sweet spot here. What dose of vaccine would confer immunity with the fewest side effects? In the case of the Pfizer vax, they settled on 10 micrograms. But that brings us to the pretty common idea that kids have these really strong young immune systems and they don't need a vaccine to fight COVID.
Yeah, so I think a lot of people call this natural immunity, if you may, and there is quite a few kids that have quote unquote natural immunity. A study from the CDC said about 38% of kids do. But what that tells me is, one, there's a ton of kids still susceptible. And then two, natural immunity is very random again. Some people get a very protective response that will last months and months and months. Some people won't even mount a response at all. And the challenge is we don't know, we can't predict who will fall into each category. And so the safest thing to do right now is for everyone to get the vaccine, to one, know that they're covered, and then two, to prevent reinfection, because we're just not confident on the longevity of this natural immunity or infection-based immunity.
And then there is the big scary one to me, multi-system inflammatory syndrome in children that we talked about with Stephanie at the beginning of the show. Known as MISC or MIS-C, it's an extremely serious potential complication of COVID. It's called multi-system inflammatory syndrome because it can cause potentially deadly inflammation in any of a child's body system. So their heart, their lungs, their kidneys, their brain, skin, eyes, their gastrointestinal organs. So that's why the symptoms can be so varied. Stomach pain, bloodshot eyes, those red eyes Stephanie was talking about, diarrhea, dizziness, rash, vomiting. It's brutal. MISC is a post-COVID syndrome. So sometimes kids whose COVID was so mild they were never diagnosed have come down with MISC seemingly out of nowhere. Then they test positive for COVID antibodies. Now, not many kids get MISC. CDC reports only 5,526 cases, but 48 of those kids died. And if your child dies from something like this, it doesn't matter at all how rare it is. So MISC is a short-term complication of COVID infection in children. We know about some of those, right? What we'll be learning about for decades, though, are the long-term complications. We are only beginning to understand this disease.
Yeah, absolutely. Yeah, so we have the case numbers, we have the hospitalization numbers, but there's also other, long-term impacts this pandemic's had on kids. And that's one of them is the long COVID. We've been having a really hard time estimating long COVID because the symptoms they range so drastically. But it looks like long COVID's about, 7 to 8% of kids will experience long COVID. And this ranges all the way from fatigue and headaches to even trouble concentrating, chronic muscle and joint pain and cough. And it really impacts their quality of life, limitations to physical activity, feeling distressed, mental health challenges, decreased school attendance and participation. And so you're right, we're seeing long COVID 6-8 weeks plus after initial infection. But what's even scarier is we don't know what's going to happen in 5, 10, 20 years among these kids. Some adult research has shown that long COVID can contribute to decreased brain matter. And so again, we're just really not confident in our knowledge of long COVID. And it can be burdensome for sure.
But this is the thing, right? Some of the vaccine hesitant parents are vaccine hesitant because we don't know the long-term effects of the vaccine either.
That's true. We don't know the long-term impact of the COVID-19 mRNA vaccine. We have about 12 months, 15 months of follow-up data from the original clinical trials, but that's it. But I think a lot of people don't recognize or even realize that our research in mRNA started back in the 1960s. And our clinical trials started in the 90s and 2000s. And so we've had these mRNA biotechnology for quite a while, and none of those clinical trials did long-term effects pop up. The reason those clinical trials didn't go to full FDA approval wasn't because of the safety, but was because of the effectiveness. We just didn't figure out a way to get the mRNA because it degrades so quickly to your cells in an effective way. And we happened to try fat bubbles for the COVID-19 vaccine, and thankfully it worked amazingly beyond our expectations. And so you're right. We don't know the long-term effects of the vaccine, but we know a whole lot about mRNA and we know a whole lot about the human body where there's just no biological plausibility that long-term effects would happen.
Okay, I have some pediatrician questions. Dr. Wolovitz, I got my booster last week, and I did the same thing for that I did for my first 2 shots. I hydrated a bunch, and then after my shot, I took an anti-inflammatory. So what do you tell parents of your young patients to do before they head into your office for a shot?
Yeah, I mean, I would make sure that your child is fever-free and is, feeling well on the day of the vaccine. Since it's cold out, I would say, the vaccine's going to be administered in the arm. So it would be helpful to wear like a t-shirt under your sweater or jacket so they're not having to, take off their long sleeve shirt or sweatshirt in the pharmacy or pediatrician's office. I think being well hydrated is great. The recommendation is that children be observed for 15 minutes after their vaccine. If a child has a history of anaphylaxis to anything and you regularly carry an EpiPen, this would be a good time to still bring your EpiPen. Although any vaccine administrator should also have an EpiPen, but if your child has a history of anaphylaxis, this would be a good time just to bring it, just to be safe.
I've talked to docs who give a hard no to pre-medicating. So no Tylenol or ibuprofen before the shot.
Yeah, you can take Tylenol or ibuprofen afterwards if your child does run a fever or has a particularly sore arm. But the majority of kids aren't. So I wouldn't give it prophylactically, just if you need it.
So here's the real test of how comfortable these two experts are with the Pfizer-BioNTech COVID vaccine for kids. Jedalina and Wilovitz are both moms. Will they take their kids to get their shots?
I have two that are eligible in this age group. And so that's fantastic. And I'm so excited. I won't be giving them the vaccine. They'll be going to their pediatrician's office. But yes, I'm very excited. And then my youngest, who's 4, is in the Moderna trial.
Yeah, my daughter is, one of my daughters is 2.5 and the other is 13 months old. And so, we're next in line. And so that date can't come soon enough. So we can finally put COVID as a vaccine preventable disease for the entire population. Still,
Both moms and I understand the hesitation of other parents, the wait and see parents.
Yeah, there's a lot of wait and see parents, and I think that's okay. I would encourage them to talk to their pediatrician. The pediatrician really knows the history of the child and their medical history the best. And so they're really there to stop and listen. I would also try and identify what you're waiting to see. Are you wanting to see more children, the real world effectiveness of this vaccine? Are you wanting X million of children to get this vaccine? I would set a goal to see what you're waiting for. Because if you're waiting to see if the vaccine's effective, we've already have that evidence. Then the third thing I would say is try and identify why you're hesitant, and seek out resources, and your pediatrician may help with this too, that address that hesitancy or address that misinformation or address the science that you're uncomfortable with. So you can make evidence-based decisions, not decisions based on fear. And so I think together, there's like I said, a lot of parents that are waiting to see, and we have to be patient with them and sit down and really answer a lot of questions, really good questions that they have.
There's some chatter that getting this age group of kids vaccinated could break the back of this pandemic in the United States. Schools will become safer and families will become safer if little ones are less likely to bring the virus home. So it seems logical that this is a really big step. But is it?
It's enormous. It's absolutely huge. You have all of these school-age kids that are vulnerable. And, I think the estimates are that perhaps up to 42% of children have had a natural infection and have some type of immunity. Of course, that's hard to quantify, and it is recommended that children who've had a previous COVID infection do get the COVID vaccine to protect them for future variants. But this is huge. This is, a significant chunk of our population, and there's no way we'll reach herd immunity without them.
The more people we get vaccinated, the closer and closer we get to this darn end of this pandemic. And I think a lot of epidemiologists are hopeful that spring will move into an endemic state. And I think there's a lot of value and optimism. And so we'll see what happens. To be determined.
Thank you to both epidemiologist Caitlin Jedalina and pediatrician Dr. Ellie Wilovitz. I have been really worried about elementary school-aged kids since it became clear they'd be going back to school. The only age group in these big congregate settings without access to vaccines. And many of them wouldn't even have masks to protect them. So it was worrying, right? It felt to me like we were marching our kids into a kind of war and putting them on the front lines even without any weapons at all to protect them. I knew they needed to be back in school as soon as possible. We all knew that, right? But they were so vulnerable. But now they have access to safe, effective protection from the deadliest effects of COVID. And if they get their first shot as soon as they can, they will likely have full immunity by the time their winter holiday breaks roll around. That's not just good news for their health, but for their parents' health and their grandparents, for their vulnerable friends and family members. Now, even if they get both shots before Thanksgiving, no 5 to 11-year-old will have full immunity by Thanksgiving Day. Like adults, they need 2 shots 3 weeks apart, and they're considered fully vaccinated 2 weeks after their second shot. So even Hanukkah will be mostly outside that immune window for most 5 to 11-year-olds this year. So parents will still need to take all the well-known precautions for just a little longer, masking, keeping distance, all the stuff we're old hands at by now. By Christmas, by New Year's, by the time kids go back to school in January, usually bringing with them all the viruses they picked up at Grandma's house over the holidays, these kids should have all the protection afforded to them by being fully vaccinated. No more unarmed frontline soldiers in this war against this virus. That's good news. That's very good news for all of us. This episode of Petri Dish was produced by me. Our executive producer is Fernanda Camarena. Additional production, music, and sound design by Jacob Rosati. TPR's news director, Dan Katz, edited this week's show. And special thanks, as always, to Mark Bemmett. Petri Dish is a production of TPR and the Texas Newsroom, a collaboration of public radio stations across Texas and NPR. I'm Bonnie Petrie. Talk to you soon.